Hello, my name is Pooja and I'm thrilled to present my analysis on multiple predictive models for predicting the treatment effectiveness for refractory patient population using Spark. Many studies have shown that 30% of epileptic patients do not respond well to anti-epileptic drugs. There are 26 AEDs available to treat different types of seizures. Some patients continue to have uncontrolled and recurrent seizures even after treatment with multiple AEDs. The consequences of using multiple AEDs have been well studied. In one study, they found a significant positive correlation between periodontal disease and seizure severity. This affects the patient's oral hygiene. The patient continued to suffer with deleterious effects on their health and quality of life. Many studies have shown that early diagnosis of patients with very poor response to AEDs can improve patient care. The patient can be given alternative treatments which will dramatically reduce the effect of AEDs. In this project, I've taken the epileptic population data to develop a predictive model to predict the treatment effectiveness of refractory patients. A refractory patient is defined as a patient who fails to achieve a control of seizure after treatment with 5 or more AEDs. A non-refractory patient is defined as a patient who has at most 2 AEDs with success at the end. For this project, I follow the predictive modeling pipeline discussed in the class. The prediction target will be the refractory and the non-refractory patients, which is followed by cohort construction, feature selection, predictive modeling, and evaluating performance of the models. Cohort construction. We have a patient population of roughly 257,000, of which 4,432 patients have been treated with 5 or more AEDs. There are at least 5,793 patients with success after 2 AED treatments. This will be the cohort for this project. I used patient diagnosis procedures and counter events such as inpatient, outpatient, emergency admission, hospital days for inpatient, medication with supply days and quantity of medication, and also gender of the patient. I filtered all the events in the cohort as a first step. I made a couple of improvements from earlier iteration of the project, namely using the larger data set for modeling and then changing the index date to include only events within the observation window, which is 2 years before the index date. The index date is the date on which the first AED was administered. The events for cohorts within the observation are selected for predictive modeling. I used 4 different algorithms for predictive modeling. The 4 algorithms are support vector machine with stochastic gradient descent, logistic regression, random forest, and linear support vector classifier. I used different hyperparameters to optimize the performance of the model and finalize the shown hyperparameters. The models were evaluated against different metrics. Accuracy simply measures how often the classifier makes the correct prediction. It is the ratio between the number of correct predictions and the total number of predictions. 3 linear models give a very high accuracy score. AUC stands for area under the curve. Here the curve is the receiver operating characteristic curve, or ROC curve for short. The ROC curve shows the sensitivity of the classifier by plotting the rate of true positives to the rate of false positives. Again, the 3 linear models give a very high AUC score, showing that many correct positive classifications are gained with more and more false positives. RMSE is the most popular evaluation metric used in regression problem. It follows an assumption that errors are unbiased and follow a normal distribution. All models show lower RMSE score. A learning curve is a plot of training and cross-validation error as a function of number of training points. The distance between the training error and testing error will show overfitting, variance, and bias in modeling. The SVM with SGD has very small gap between training and testing error, meaning very low overfitting with low variance. The logistic regression has the best learning curve, and the overfitting is almost negligent and very beautifully converged. This is very supportive of the evaluation metrics for logistic regression. The learning curve for random forest randomly converges, but the evaluation metrics are not very supportive. Hence, we can conclude that random forest is not a good fit for this. The linear SCV also performs similar to SVM with SGD, with a smaller gap between the training and testing error. We see that all the 3 linear models have performed very well with this dataset. We see that all the models' error rates decreased as we increase the proportion of training data. Therefore, using a 70 to 30 ratio of training and testing data is a good way to eliminate overfitting and underfitting of the data. One challenge I've had from the beginning was scaling up the analysis to the larger data set. I tried to use AWS and it took a lot of time to get that working. For some reason, I could not get them working on all clusters in parallel. I resorted to splitting the files into individual feature files and storing the data in RDD. I also learned that array contains expression for filtering can be very expensive and time consuming, and using joins for filtering is faster and scalable. Also, serializing with CRAO and partitions help to speed and scale for large data. The conclusion is that the models were built successfully and linear models are very promising for purpose of predicting treatment outcomes. There are a large number of features for this dataset, and using dimensionality reduction can help fine-tune the model. The large dataset was also very useful in showing reduction in overfitting of data and balancing bias and variance. I hope you find my analysis helpful and useful. Thank you.